We had been talking about sedentary life, sportsman, sports culture in India, everything for fitness, especially for the doctors and all. So I think they all are focusing down to ultimately, scientific part of it. The what ultimately it lands up with. If you are not keeping yourself fit, you are not doing exercises, you are not taking care of weight and all. The what you are going to land up with is dyslipidemia. And before we start with the dyslipidemia and the recommendations of the Lipid Association of India, why it's important? Because India is in the middle of atherosclerotic cardiovascular epidemic. If we see in India, we Indians are almost 3 or 4 times more prone to cardiac disease than Americans, 6 times more prone to cardiac disease than Chinese, 20 times more prone to cardiac disease as Japanese. So, as such, by birth, we are more prone to cardiovascular disease. Plus, coronary heart disease manifests almost a decade earlier in India than Western countries. Almost 25% of the major MIs occurring in India are in the age of group of less than 40 years. And all the more 50% of the deaths occurring due to MI are less than 50 years of age. So such is the burden of cardiac atherosclerotic cardiovascular disease, which is in India, and it is increasing most rapidly in the younger people, especially in the age of 40 years. So, what is the culprit? Dyslipidemia, cholesterol. Cholesterol is a basic cardiovascular risk factor. As we were talking about the silent killers, about the stones and whatnot, is the major silent killer which is slowly, progressively going to take to you the death with the cardiovascular problems and all. So, going in with a scientific way, the role of LDL cholesterol and other ApoB containing lipoproteins in the development of atherosclerotic cardiovascular disease has been demonstrated by genetic, observational and interventional studies. So, we have to be very careful in dealing with the cholesterol levels and dyslipidemias. In day-to-day practice, daily we see reports of the lipid profile. We see that somebody's LDL is about 110, HDL 210, total cholesterol 223. We just pass it off. Okay, no problem. You take care of diet and this thing, that thing. But I think as practitioners, as physicians, as cardiologists, as endocrinologists, or even any specialty we are dealing with, we have to be more scientific and more dogmatic in our directions to the patient. If we see this diagram or the map of India, in this ICMR study, Punjab, we can see that is it working? No. Almost 25% of the people are in Punjab are having hypertriglyceridemia. More than 25% are having high LDL. And most importantly, 60% of the people in the Punjab are having very low HDL. This is a very important thing which is generally ignored. And almost more than 15 to 25% of the people are having triglyceridemia. So for that, in general, what we were saying or what we reiterate again and again, lifestyle modification is the main thing to control the dyslipidemia or manage dyslipidemia, and Lipid Association of India also goes for that as the first line of management in the form of adoption of a Mediterranean diet pattern like vegetables, fruits, whole grain, low dietary products, poultry, fish and legumes. Combination of oils rich in MUFA and PUFA rather than trans fats we should be taking, and limiting the intake of sweets, sugars, sweetened beverages and meat. Physical activity, as we were saying, 150 minutes per week of moderate intensity or 75 minutes of vigorous intensity aerobic physical activity or equivalent or combination of both is required or is advocated spread throughout the week. Muscle strengthening exercises also at least 2 days per week. As far as the alcohol intake is concerned, should preferably be avoided by Indians. Maximum up to 1 drink for females and 2 for males. Here again a rider for males who are having age more than 65 or any comorbid conditions or diabetes, we shouldn't be advocating even 2 drinks for males per day. Complete abstinence from tobacco containing products and above all stress management and adequate sleep. So I always say 5 pillars are important when you are dealing with the non-pharmacological measures as far as your fitness is concerned. Weight control, diet control, stress control, proper sleep and adequate physical activity. And in diet, low carb, low fat, fat with a high MUFA, and of course 7 to 8 hours sleep, as was advocated by Dr. Claire also in the earlier talk. So that was in general for all people. But once we are dealing in our day-to-day OPD practice or otherwise, as anybody walking to your OPD as patients, we will be wiser, or we should be making them wiser by doing risk stratification with respect to the possibility or risk of the cardiovascular disease which they are going to have. So the major risk factors or markers are age more than 45 in males or 55 in female, family history of premature atherosclerotic cardiovascular disease, current cigarette smoking or tobacco use, high blood pressure and low HDL cholesterol. So these are the 5 major risk factors. And in India or in our day-to-day practice or in Punjab, we can easily see, any person who is having the middle age or a 55 old male person coming to you is a smoker or is having hypertension. So straightway falls into the high, major risk category of developing cardiovascular disease or coronary artery disease. Apart from the major cardiovascular factors, we have other high risk features, diabetes with 1 or 0 to 1 or other major factor, CKD stage 3B to 4, familial hypercholesterolemia, extremes of a single risk factor which we were talking in the 5 risk factors, coronary calcium score of 300 or more HI units, non-stenotic carotid plaque or lipoprotein A more than 50. Desirably is less than 30 or 30, but it is more than 50. So these are the other high risk factors. And certain modern non-conventional risk factors are coronary calcium score of 100 to 299, increased coronary carotid intermedia thickness, lipoprotein level of 20 to 49, impaired fasting glucose, increased waist circumference up to more than 90 in males and more than 80 centimeter in females, ApoB more than 110, desirable limit is less than 90, and HSCRP more than 2 on different occasions. So these are the moderate risk factors, high risk factors and major risk factors. Now once we know the risk factors, we categorize people whether they fall in the low risk or the moderate risk or the high risk or very high or extreme risk factors. So any person who is in the having only 0 to 1 major risk factors and has a lifetime risk factor of CVD of less than 30% is at low risk. Any person who is having 2 major risk factors and 1 low risk factor and lifetime CVD risk is more than 30 is of moderate risk. In the high risk category, 3 major factors, like I was telling earlier also, any person who comes to you with the age of 50 plus, is a smoker or is a hypertension, already has 3 major factors, or any of the 2 major risk factors or 1 high risk factors, is in the high risk category of developing coronary artery disease. And in very high risk factors, if the person already has had a coronary artery disease earlier or is diabetic, with 2 or more major risk factors falls into that category, or has a family history of homozygous hypercholesterolemia. In the extreme risk group, we have category A and B. Any person who is having CAD with more than one feature of the high risk group, and other category is having CAD with very high risk of the ACS with one LDL cholesterol less than 50. So these are the 5 groups which we divide. We can divide the population or the people in our practice, whether anybody is in having extreme risk or moderate risk or high risk of developing coronary disease, and accordingly guide the person or manage his future life and prevent him going from the silent killers. So now once we have achieved we have stratified the risk categories, we have our targets. These are the targets which will help you and your patients to adopt that lifestyle, and also if needed be any medication to get the ultimate goal of better quality of life and ultimately longevity of life in the later years of life in the age. So anybody who is at the low or moderate risk, we have the targets of LDL cholesterol less than 100 and non-HDL cholesterol less than 130. Anybody who is in the high risk group, we have the targets of LDL cholesterol 70 and non-HDL 100. Further, we have in the very high risk category, LDL 55 and non-HDL 85. And in the extreme group, it is as low as LDL cholesterol 40 and non-HDL as 70. So these are the goals of all the 5 categories. And frankly speaking, I will also confess, in our day-to-day practice, we ignore these guidelines and we ignore these targets. We just tend to tell, you see the prescription, okay, anybody you are getting already atorvastatin or you are getting rosuvastatin, okay. We dare not tell the person, no, you are not achieving the target, you are getting the underdose, or you are not observing lifestyle modifications to achieve the target, which will actually benefit you from developing the coronary heart disease or atherosclerotic cardiovascular disease in the later years of life. So now, how to achieve it? Once we have known which are the risk categories and what are the risks and what are the targets for different groups, how to achieve that? On one hand, we have repeatedly said, reinforce lifestyle measures in the form of diet, exercise, weight reduction, smoking, quitting, and alcohol restriction, control of diabetes and hypertension on the other side. Plus, now comes the role of medication. The high intensity statin we have to start, and if the LDL cholesterol is more than 50 after 3 weeks or up to 3 months, apart from the lifestyle modification and dietary restriction and control of diabetes and hypertension, it is advocated that we add the adjutive MIV along with the statin and achieve the target. Still, if the patient has still LDL cholesterol more than 50, we should consider addition of bempedoic acid or PCSK9 inhibitor, monoclonal antibodies like inclisiran and all, so that ultimate goal is achieved and the patient gets a really benefit. And you all know what are the statins available in India. High intensity are atorvastatin in the dose of 40 to 80 milligram. I don't think in our day-to-day practice anybody in the audience is prescribing 80 milligram atorvastatin. No. And you will see so many patients or people, ladies coming to you, sir, मैं तो कुछ खांदी नहीं जी, मैं तो घर दा सारा काम करदी हैं जी, ये पता नहीं कित्थों वधी जांदी है. I tell them in Punjabi plain language कि cholesterol हवा या पानी नाल नहीं वधदा. It should be very simple and in curt manner you should tell the people कि it is either your diet or lack of physical activity or lack of exercise which is increasing this. In spite of the fact you are taking the medicine, you have to step up the medicine, otherwise there is no fun of continuing with the medicine with the underdosage. Okay? And same is toward the rosuvastatin, not 20 to 40 milligram is the actual high intensity dose if you really want to achieve the results for the patient. So, management of dyslipidemia, ACS is the next lecture. I won't go into the details of it. A word about the triglycerides and atherosclerotic cardiovascular disease. It has been seen from randomized trials that individual with mixed hyperdyslipidemia, that is elevated triglycerides, elevated LDL and low HDL, which is the typical lipid profile of Indian patients, have the highest risk of cardiovascular events. Also, elevated triglycerides more than 150, even if LDL cholesterol is less than 50, have the more risk of MI as well as a mortality. You have achieved LDL cholesterol less than 50, but if your TGs are high, still you have the high risks. So, in Indian population, we have to take care of the triglycerides also. And we all know from our residency times that optimal value is less than 100, normal is less than 150, borderline is 150 to 199, and 200 to 499 is the high TG levels, and more than 500 are very high TG levels. And it has been seen for triglycerides, it may be fasting or non-fasting. You may achieve get the fasting value or non-fasting value, because in most patients there is a clinically unimportant increase of triglyceride concentration by 18 to 30, 60 milligram per deciliter 2 to 6 hours after the. So, just to repeat, Indian have ethogenic dyslipidemia in the form of high TG, high LDL cholesterol and low HDL cholesterol. LAI recommends both fasting and non-fasting lipid profile in Indian subjects for, as I told you, fasting for LDL cholesterol and non-fasting for postprandial hypertriglyceridemia. And most of the common agents which they are responsible for lowering hypertriglyceridemia are fibrates. They cause 30 to 50% reduction, niacin 20 to 25% reduction, omega-3 fatty acids up to 20%, statins of course 10 to 30% reduction, and GTMide they cause 5 to 10% TG reduction on the long term basis. So now how to once again, this is a very beautiful diagram, flow chart showing the management of hypertriglyceridemia. And patients with a more than 150 TG levels try to achieve the non-HDL goal and implement lifestyle modification. Just to repeat, increase physical activity, diet control, weight control, stress control, proper sleep, and treat secondary causes like diabetes and thyroid, hypothyroidism. If we achieve the normal HDL, non-HDL and TG levels, continue with the lifestyle interventions. Or if the person continues to have high TG or atherosclerotic prevention and there is no diabetes, we still lifestyle modifications plus lower the triglycerides with statins or non-statin drugs like niacin or fibrates. But if they are still, in spite of the lifestyle interventions, statins and fibrates and all, we still don't get that result, we can add further latest non-statin drugs, that is ecospent ethyl IPE we call it. Okay. But if the person has high or familial hypertriglyceridemia more than 105, here we are countering or trying to achieve the prevention of pancreatitis in such patients along with the cardiovascular problems. So, apart from intensive lifestyle modifications, low fat diet, fibrates, omega-3 fatty acids, seraglitazar has been have been showing good results in a couple of few years to achieve better results for prevention of pancreatitis with the lowering of triglyceride levels. If still the results are not achieved, the person can be referred to the lipidologist or the latest NG-PILT3 antagonists. They cause lipoprotein lipase and endothelial lipase activity by clearing the more lipoproteins from the liver. They are the latest drugs in our armamentarium. So I won't go into the detail of comparing the different guidelines of the different associations. Just to conclude that healthy lifestyle should be emphasized across the course of life. All guidelines strongly advocate LDL should be our primary target, and the intensity of treatment should increase as the risk of the patient increases. Lower the better and earlier the better reduction of LDL cholesterol, and no threshold is adverse. So as far as the Lipid Association of India is concerned, it lay emphasis upon early screening. After 20 years of age, every year annual screening should be there. We should be identifying the Indian type of lipid profile pattern, that is high cholesterol, high LDL and low HDL, and high triglyceridemia. We should be knowing about it. Premature atherosclerotic cardiovascular disease in the family history is important. Lipoprotein level estimation and ApoB lipoprotein estimation may be important in Indian patients. Achievement of non-HDL cholesterol targets is as important as the achievement of LDL levels. And there are no adverse side effects of very low LDL cholesterol. So we should go for aggressive management of LDL management and non-HDL management in Indian subset of patients as compared to the Western counterparts. Thank you very much.